Welcome, everyone. As folks sign on, I'll just set a little bit of context for today's seminar and learning series. So the Canadian Primary Care Research Network's mission is to facilitate research to spread and scale innovations in primary care. This is the third of 3 sessions that focus on the persistent but also pressing issue of access. If you missed the first 2 on workforce planning and connecting patients to care, you can catch those on the learning series section of the CPCRN website. Just pop the link here. So I'm the Nova Scotia member of the CPCRN steering committee. And as such, I'm based in Mi'kma'ki, the ancestral and unceded, as well as present and future territory of the Mi'kmaq people. I also want to recognize that African Nova Scotians are a distinct people whose histories, legacies, and contributions have enriched this part of Mi'kma'ki for over 400 years. Given today, we'll be focusing on patients who don't have a regular source of care. It's important to consider that according to the most recent data we have, significantly higher percentages of First Nations people, especially those living off reserve, report being without a regular healthcare provider compared to people who are not Indigenous. And this is true in all provinces and territories. And this is true despite Truth and Reconciliation Commission's calls to action that directly speak to the need to close gaps, address jurisdictional disputes, and fund healing centers. So yeah, today the focus will be on meeting the needs of unattached patients. We'll explore the current context for unattached patients and what we know about their experiences in primary care needs. And then we're going to focus on policy approaches implemented in Nova Scotia and Quebec aimed at meeting the immediate healthcare needs of people who are waiting for a place of attachment, and consider challenges and potential tensions in meeting these immediate needs for care. I'm going to start things off by turning to my colleague here at Dalhousie Family Medicine, Emily Marshall, who's going to set the stage regarding unattached patients and research about their experiences in primary care needs, drawing on cross-provincial research she's led. I'll then turn to Colton McDonald, a policymaker here in Nova Scotia, who will talk about approaches Nova Scotia has put in place aimed at meeting immediate needs of unattached patients. We'll then turn to Mylène Breton, who will describe related policy approaches in Quebec and relevant research findings. They'll each speak for about 10 minutes. We'll pause for questions of clarification specific to each of their presentations between them, and then save time for broader discussion to anything that cuts across multiple presenters at the end. A final reminder, you'll receive a survey after the session. We really appreciate your comments, and suggestions are used to plan upcoming sessions. So without further delay, let me turn it over to Emily Marshall. Emily, take it away.
Great, thank you so much. I'm just going to pop up my presentation, share. Is that sharing my screen to you now? Yeah, okay, great.
Good to go.
So great, thank you so much. I really appreciate this opportunity to talk about some of the research that I've been doing over the last several years. And I recognize that my colleague Ruth has given a very lovely statement about our gratitude for the lands that we work on. So maybe I'll just pop right into the next parts of my presentation. So I'm actually going to start with something a little personal. I couldn't find a family doctor when I moved to the Dalhousie Department of Family Medicine to take up my faculty position in the department back in 2015, which is, we didn't really talk a lot about access to primary care at that time. I was coping with an undiagnosed health issue at the time, and I was unable to get a family doctor, despite being told by my colleagues that we had the most per capita family physicians in the country, and I couldn't get a walk-in clinic to give me a referral to anywhere to see a specialist. So I chose not to use my social capital at Dal Family Medicine to find a family doctor. And I started cold calling primary care offices, just like many, many Canadians have been doing for many years now, to no avail. And then I finally did get a family doctor about 3 years later who referred me, and I saw a specialist within 4 months and had surgery 2 days after seeing that specialist. So that experience led me to ask a lot of questions about what is going on with access to primary care. And I developed something called the MAP study, which is the Models and Access Atlas of Primary Care. And we did census surveys with all primary care administrative staff, family physicians, and nurse practitioners with really high response rates. Data were linked then to administrative billing data for provider and patient outcomes. And I just want to talk about some specific findings related to patient access. So we found that patients of providers who were soon to retire were older and had more chronic conditions, which meant that they were going to have a patient cohort that needed care that was more complex. We saw that less than 10% of providers were accepting new patients unconditionally, and that 27.9% of providers were reported by their receptionist to be accepting new patients, but would not take patients who required opioids or narcotics. And only 20% of providers who conditionally accepted patients would take new patients who required prenatal care. And 47% of providers who will accept new patients conduct unbilled meet and greet appointments before accepting new patients into practice. So a question arose around, why are primary care providers so reluctant to take on certain kinds of patients? So we know that one of the challenges that they talk about are the wait times for specialist care. And this table from the OECD shows us that we have some of the longest wait times for getting people from primary care into those specialist care appointments. And when we did interviews in the MAP study, we looked at the effect of that specialist wait times on primary care provider access. And they talked to us about the pervasiveness of long wait times, the provider's experience of burnout, that they're trying to manage beyond their scope of practice that they're comfortable with, that there are consequences for their patients that are challenging emotionally on them, that scheduling and repeat visits reduces the overall capacity of how many other people they can see, that they're managing the patient expectations through that process. And there's also the additional work of strategizing and referring their patients to get the care they need. So this indicates that the problem is broader than just primary care, and that it's a whole system solution that's really required to improve access for patients. So the top 3 provider suggestions to increase accessibility were to have more mental health services and supports, to have changes in payment that actually reflects the work that family physicians need to do, and nurse practitioners, and to fund more nurses and more teams, and also to have more collaborative care team models established. So this data is actually from fairly old research, but it was definitely being talked about back then as well. So the main suggestion is again around this more needed support. Moving on to the puppy study, which is a newer study that Mylène Platon, one of my co-presenters here today, is very much part of, leading the Quebec arm of the study. We know that there have been some strategies for trying to attach patients across the provinces. In Ontario, they have something called Healthcare Connect, and currently has about 2.2 million people without a physician. And they're estimating to have by 3 million unattached patients by 2025. In Quebec, they have the Primary Care Access Point, or GAP. And in Quebec, the patients that have a family doctor dropped from 83.1% in 2019 to 73% in 2023. And in Nova Scotia, we have something called the Need a Family Practice Registry. And as of June 1st, there were more than 160,000 people on that registry, representing about 16.2% of our province's population. So we know part of the reason that we're seeing this is we do have a growth rate in the population, but that's certainly not the only reason that we're seeing. But because of all of these things around access to care, we developed the UP study in Nova Scotia, which is around what is patient access to primary care and what are the consequences of the unattachment for patients. And we did interviews with participants in Nova Scotia that included people with acute primary health care needs, people who are well but see access as a fundamental right and are concerned about accessibility, and people who do not have acute needs but anticipate a need for primary health care in the future. So there were 4 main findings from this research. The first was around the consequences of unattachment. And it's hard to express the level of concern that people had by just sharing these slides, but I hope you'll see the quotes on the side, and I'll focus on some of the text on the left. So they talked about care burden and that need to try and make sure they had their own information and getting even access to their medical history in order to navigate the system, and also the costs associated with those types of things. That they had lost care. They weren't known by the providers that they did get to see if they got into one. There wasn't a lot of medical follow-up. It was hard to get prescriptions and referrals. They talked about the health impacts. The one positive might be that some talked about how making lifestyle changes so that they'd be more healthy and wouldn't need care. But they also talked about the condition-specific health impacts, having incorrect, missed, and delayed diagnoses, having to self-diagnose and medicate themselves, and also just giving up and not seeking care at all. Overall, those negative feelings and stress led to a lot of concern for the future, demoralization, and having a lack of provider choice. So there were certain strategies that people would use. Most commonly, they would sign up for any unattachment patient registries that were available. They would try and find interim primary care providers. They would do cold calling of primary healthcare practices. And they talked about how demoralizing that would feel. They would use their personal networks and expanding the geographical area of where they were willing to see care. And sometimes people talked about just giving up altogether and feeling like they wouldn't be able to access care. They also talked about accessing care while unattached and using walk-in clinics, emergency care, and specialists or other health professionals. So if they had a specialist, they'd kind of cling on to them and say, I can't see anyone else. Let me keep coming back to you. And they also talked about paying out of pocket for other services. The negative feelings and stress were very clear. There were a lot of concerns for the future, having exacerbation or recurrences of their current health issues, feeling demoralized and like a beggar when trying to seek a new primary care provider, and having frustration with a perceived lack of choice. So the overall conclusion is that while unattached, much of the process of healthcare becomes the patient's responsibility, and this is burdensome and contributes to poor health and social outcomes for our patients. Potential for inequitable care or reattachment along socio-demographic axes is so those who are more educated or have more resources might be more likely to find alternative care or new attachment was prevalent. Unattached patients may benefit from structural interventions to ensure adequate primary care workforce and patient registries and waitlists for patient attachment. And if you want to read more about this, we did publish a paper on this research. Moving to the puppy study that we led, there's just a few findings I was going to share, and I can't see the top of my screen, and I just moved forward by accident. So let me see if I can go back. Anyway, not to worry, but there were a number of things that happened during the pandemic, and I'm not going to bother going back because I know I'm running low on time anyway. But the next steps for our puppy study are around launching a new survey that's going to go to Nova Scotians, those in Ontario and Quebec, around the experiences of access to primary care. And we have a new follow-up to the UP study, which is an unattached patient study that's under review currently in Nova Scotia. That's going to tap into folks who may be underserved. And then we also have a special edition that I wanted to point out called in Healthcare Management Forum that deals with a number of things related to patient attachment and other things related to primary care. So it might be something that people would be interested in having a look at. So those are the rest of my slides. Really happy to answer questions and looking forward to the other presentations because I know there's a lot more interesting information. This is some of my contact information, and I'm happy to share the slides with anyone in the future if you'd like. And I will stop there.
Thanks so much, Emily. Really appreciate the personal perspective you bring to it. There were some requests for resources and publications in the chat. Any other questions of clarification before we move on? Okay, then without further delay, Colton, let me call on you. Really interested in this topic viewed from your vantage point.
Okay, thank you. You can hear me okay? Okay, great. Okay, well, thanks so much for the opportunity to connect and share some of the work that we've been doing over the last number of years in Nova Scotia. And it's kind of interesting to do this right after Emily because much of this work has been informed by Emily's work and others. So I'm Colton McDonnell, I'm Director of Primary Healthcare in Central Zone. in terms of structure for our zone primary healthcare leadership, we also have a family medicine leader, a department head, and a clinical network. So the work that that I'll describe here has the benefit of being, having input and leadership from all three of those entities, as well as, of course, from providers, and in at least many cases from patients directly as well. So yeah, I'll move on to the next slide there and get right into it with a little bit of context. So as Emily said, in Nova Scotia, we have what we call the Need a Family Practice Registry. So it's a provincial registry that's linked with our 811 registered nurse advice and information line for indicating that you're someone who doesn't have a regular nurse practitioner or family doctor. So we encourage or ask everyone across the population to register, and similarly, as folks are setting up practice, we ask or strongly encourage or support people to accept patients from the Need a Family Practice Registry as well. And in terms of tracking and data accountability, things like that, when people do accept patients, we reconcile as much as possible those names off the registry to keep the information up to date. So I want to talk through what we call our primary care clinics. So as Emily indicated, we have, as of June, we had about 160,000 people without a regular provider, and that comprised about 16% of our population. So we've had a number of iterations of what we call primary care clinics, and therefore clinics that are focused on folks that don't have a regular provider. In the current state, we have 19 of those across Nova Scotia. They started as fully unattached environments, so largely nurse practitioner led clinics that were providing interim primary care for folks that had been on the registry the longest. So we looked at by network geographically. So Nova Scotia is divided into community clusters and community health networks and community clusters. So overlaying the registration date per network or per cluster, people were linked to a primary care clinic based on how long they had been waiting. And the goal of that work was to provide interim care for folks that had been waiting the longest. And doing a really good comprehensive health history, getting people up to date, starting to deal with acute issues, chronic disease management, etc., to give them a really good head start when they moved into what at the time we called a permanent health home or community-based clinic. Some of the lessons learned from taking that approach were that the timing of the transfer of care was so variable because we have so many networks and clusters across our zone, and so many people that are accepting patients through different onboarding styles and different approaches, that often the team would just have gotten started doing the work and then even sometimes find out that the patient had already transferred and they didn't know that they transferred, or they transferred and the care was repeated by the provider that accepted them into the care. So from a patient standpoint, we found that it was some unnecessary appointments, and the value add wasn't quite there, both for patients and receiving providers. And from our providers within the clinic, they found that constant turnover of patients coming in and going out the door wasn't conducive to a whole lot of satisfaction in providing primary care. So we evolved to our next iteration, which based on all that feedback, which became a 50-50 split of attached patients to the primary care clinics alongside doing some of this transitional work on an interim basis, but moved a little bit further up the line. So we weren't working with the people that would be the very next chronologically to move off the registry, but a little bit further up. And that work was ongoing for about a year or two. Some of the feedback, again, that we heard from patients receiving that care, participating in that care, was that receiving care on an interim basis was kind of anxiety provoking. So it's always, going into a clinic where we have interim care being provided always begs the question, well, what's next? Where am I going from here? So that was just kind of a regular theme of the care. Additionally, we had virtual care NS. around November 2022 rolled out to our population across the province. So folks on the Needy Family Practice Registry all would have access to virtual care NS. So our PCCs once again evolved to providing 50% of that time being attached care, and then the other 50% of the time being in-person follow-up care for folks that had been seen on virtual care NS and were determined to need an in-person assessment or consult. So that's a little bit of the journey. It sounds like it was over, I might make it sound like it was over a longer period than it was. This is an evolution of about 2 years, and we're continuing to evolve. So as of the implementation of virtual care NS around November 2022, we, as always, do health services planning about a year in advance and looked at some of the additional needs, some of the unmet needs coming from our folks that don't have regular providers. And I'll just go on to the next slide to describe that. So there were some additional clinics that were set up across our zone. So we had unattached newborn clinics. So in Halifax and Central Zone, as an example, where we have our IWK center focused on children and women's health, we have a lot of babies being born and a lot of need to connect those babies with care within 72 hours of discharge. So the zone or the system created an unattached newborn clinic. So another entry point with a whole lot of babies coming in for care within that 3-day window of when they were born. Additionally, of course, hearing from partners across the system like emerge departments and inpatient units, et cetera, always, seeing patients with defined health needs in those environments who don't have a regular provider, but clearly need some form of follow-up care. So that second bullet was the system response at the time, which was to create a request for care clinic, which was a provider to provider referral. So not just family physician or nurse practitioner, any clinician across the system could initiate a request for care patient for a bit of a defined but broad set of criteria that could include things like a new cancer diagnosis or palliative status, exacerbation of a chronic condition, etc., something that clearly has a need for care. And again, that entry point, that was yet another entry point into the system, the request for care. So we have these 19 primary care clinics, we have unattached newborn clinics, we have requests for care clinics. One that I didn't mention was newcomer health clinics, which is another interim primary care clinic that's focused on the unique health needs of people who are refugees and have a team with focused skills in that area. So bringing us to our current and future states are the recognition that there are many entry points into the system. This is very complex for patients to navigate, for providers to navigate, and even to articulate what does care provision across the zone and system look like for folks without a regular provider. So our future state is a broad evolution of all of our primary care clinics to have these 3 entry points. So request for care being one entry point, virtual care NS follow-up being the second entry point, and then the third being self-referral or same day, next day access to care for someone who doesn't have a regular provider, with support embedded from nurses and navigators to determine from a capacity standpoint that an in-person care appointment is needed, in which case it would be booked at a PCC, or a linkage, some sort of off-ramps being created to our other primary care resources that include virtual care NS, pharmacy walk-in clinics, mobile clinics, and so on. So that's a real quick overview of how we're living out some of our response to providing care for those immediate needs, and actively working and continuing to develop and optimize this. But our current goal is around integration and making the pathway clear for folks that are able to easily access and access care on a more timely basis. So that'll be it for now. Happy to take clarifying questions and certainly to participate in questions at the end.
Pausing for any questions. Thanks so much. It'll be great to hear about the Quebec side of things, and I think then plenty of time for discussion about parallels and opportunities for learning.
So hi everyone, I think my presentation, it's a good follow-up after Emily and Colton. So I'm gonna show you what we did for an attached patient, some solution and a lot of solution. It's close to what happened in Nova Scotia. So I'm gonna present the result of a research project on a gap, and I will explain what is the gap, and I do with my research, Catherine and Veronique. So first of all, Emily said we have an important problem of unattached patient, and that is become a Canadian problem. And one of the solutions that have been implemented in almost every province is to put the centralized waiting list for unattached patient. But as you know, centralized waiting list can help patient to find a provider, but that don't give an answer to the waiting list. So it's getting more popular, and at the beginning of their creation, because it's been almost 15 years in Quebec and the other province, it's really an important mechanism to attach patients. Today in Quebec, 1.5 million of Quebecois are registered in the centralized waiting list, and that don't not take into we don't count the patient who didn't register on the centralized waiting list. So it's more than this number. And if you're lucky to be healthy and you are lucky to live in Montreal, as an example, you may wait 6 years before being attached. So as Colton showed, we may have need before being attached. And Emily, you show an important case that we can observe. So and different way of designing centralized waiting lists in Canada. We have some as in British Columbia, Ontario, and Quebec. We put some prioritization. We try to attach people that are more sick before, but it's the concept, you know. We try to attach the healthy. They can wait longer, but it's not based on first come first serve, but it depends, and we have different mechanisms to try to attach those patients. So in Quebec, as I said, if you wait 6 years before being attached, you may try to have some care. So if you are not lucky and being unattached, you don't have a lot of options. You can go to emergency room, or if you're lucky, you can go in walk-in clinic, even if you are aware that you should not go to this place. So to help the navigation and to have care, the Quebec government put what we call GAP, Guichet d'Accès Première Ligne. It's relate to the centralized waiting list that to help the navigation and find care. So if you are registered on the list, you can call the GAP. They have in every region, because it has been mandated to be implemented. And you can call, and then the nurse or the clerk will do an assessment to see if you need a physician consultation. You're gonna have, and they're gonna book you an appointment with the physician, or you can be oriented to another provider. That is the whole idea of to orient the patient to the right provider to respond to the need. But something that is important to say, that is managing episode of care. That is not continuity. That is really to respond to your care at this moment. And now they can offer a follow-up to the care that you have asked, but that's it. Then it's not in the vision of what we said, Golden Conference is not at the entry point. So we did a survey in Montérégie region. It's the second most populous region in Quebec. And we send a patient survey, Millie, you're gonna like that, to each patient that are registered on the centralized waiting list. So 40,000 patients respond to the survey. And out of those 40%, half of that, 20%, did use the GAP services over the last two years. So we asked, okay, if you call in the GAP, where have you been oriented? So 50% of the patients who use the GAP have a physician appointment, and 5% of the respondents were referred to go to emergency room. So at the beginning, it was maybe the main door entry. They may have an impact. And some of them have been referred to a nurse They have some appointment available for nurse and also a community pharmacist. And something interesting, we asked, when you use these services or this place, does these services respond to your needs? And we can see that when it's physician consultation, that's almost do not have a lot of unmet need, but when they have been oriented to emergency room, 22% of the patients said that did not address their need, and it's getting close to 60% when they have been oriented to other providers. We also conduct an implementation of the gap. So they have, let's say they have almost 24 across Quebec, and we study 4 of the gap about the implementation process. And we asked and we did some interview with key stakeholders, and what we observe is they have a huge variation in the guideline. So they have been mandated to implement the gap without any tool or common algorithm or training for the clerk who were working on the gap. It was a strong, and it was in the context of human resource, and it's still so high turnover of the staff working in the gap. And we observe a huge variation among capacity in physical appointment. In some regions, they have a huge capacity and efficient response, and in other, it was more challenging. So we observe inequity among the gap. But they have some facilitator, and the most report one is really they put a lot of money on the table to be sure that physicians participate, and they participate. So the capacity of giving appointment with physician was an issue in one of the case, but they were responding, let's say, for an attached patient that come from the gap, it's sometimes 4 times the fee code of a regular patient. So you may understand that they really participate. And they have also transformation while they were implementing. We just celebrate the 3 years anniversary. They did a lot of change over the 3 years. So now we have gap numeric, that now you don't have to call in. You can register online whenever, and you can respond to a few questions, and then you can have some tool to help you to navigate. And at the end, they recommend where you should go. And after that, the patient don't wait online, because at the beginning you can wait few hours to talk to someone in the gap. Now they're calling you back. And it was really a top priority of the organization. So they put a lot of capacity and creativity around. And I'm gonna just show you in the 4 cases we analyzed, because they didn't have guidelines, and it was a priority, a lot of them create some innovation to respond to their unattached patient. One, it's really interesting, is the mobile proximity clinic. It's a paramedic with a nurse who is you have to take an appointment for more comprehensiveness. It's close to Colton, what we said, but it's a mobile clinic that if you are unattached, you can go, and it's a partnership with the paramedic and a nurse. Another place that it's really, really interesting, it's in Quebec City, they put a multidisciplinary clinic for mental health. So you have social worker, you have pharmacists. So all of the staff except family physician who give you comprehensive care assessment for a specific, if you have a mental health problem. So a lot of patients say, I prefer to continue having the following that there instead of primary care clinic, because you are not specialists in mental health. And they also develop a trajectory of pharmacists. A lot of person who call it for renewal. So now they have a trajectory with the pharmacists in the community with the gap. So a lot of creativity we observe around the gap. And finally, we observe different unintended consequence. The first one is we now have 3 different kinds of citizens in Quebec. Sadly, you have the attached patient, you have the unattached patient, and the person who is not attached at all. So, and we don't have the same services depending what kind of citizen you are. And also, what we put a lot of energy, financial resource on episode of care, and we know that that is not the gold standard. At some point, we we should have attached to a primary care clinic that is offering continuity of care with the team. So I think I will stop here if we want to have time for exchange. So Manuela, if you help me to stop my PowerPoint, I don't know how to stop it.
Thanks so much, Mylène. We already have a question in the chat, and that's about how needs are assessed and patients are prioritized within access points.
So in the gap?
So how does Quebec assess patient health and prioritize based on which information? So perhaps both within the waiting list and gap.
Yeah. That's a good question, because let's say if we talk about the centralized waiting list for an attached patient, they have 5 categories, and the category is more designed on the recommended waiting time. So the category A, you should have a family patient with less than 1 month. The category B, it's less of 3 months. But all the category are way over the recommended length. So it's something that the beginning in the creation, they design about recommended length to see someone, but we are not close to this recommendation. And as you are aware, primary care, it's a lot of, it's the population. So maybe they have some, let's say, new cancer, after hospitalization, you can be category B. If you have history, that could be category B, C, and now it's related to the your database at some point. If you have been to emergency room over the last 2 years and you have been hospitalized, the system puts you some point that you are higher in the categorization. That is for the centralized waiting list. And at the beginning, they have some variation because it has been on evaluation of the nurse, but now it's more move on your response to a survey, and depending of your response, you're going to be put in a category, and you can ask to talk to a nurse if you want an assessment. So that is beside of the gap. The gap, that is where I said they have a huge variation among the gap. They didn't have the train. They didn't care the tool of the algorithm. So a lot of gap developed their own orientation. And at the beginning, it was more, do you need a physician appointment or not? And do you are able to orient to other provider? And the other provider, the trajectory are not really formal. Some of them have developed, let's say, strategy. Okay, here the list of the pharmacists, or we have communication with the pharmacy in the community, but sometimes the patient will just say, okay, with this condition, call your pharmacist, or with this condition. So the other provider, the gap was, they didn't really work on this piece that was really, really important. And where we observed in one of them, they put a nurse in their clinic that was in the organization. Okay, now we have a clinical nurse that having spot for the gap patient when they oriented. So now we're working really to develop this piece about beside the family patient. And the gap numeric help the digital gap help that because they develop some auto soin. So the tool for the patient, if you respond to those questions, here's some tool that you can use.
Can I just stop for 2 seconds? I just wanted to add, it was a really lovely experience working with the health authority here in Nova Scotia, because we used to not prioritize patients based on their healthcare need. And one of the things that happened out of that research I shared with you with patients is that they thought it was actually important to do that, and that it was more equitable to make sure that the people who had the highest needs might get in. And that research we took to the health authority, and they actually changed the system so that they would use a short survey to gather some health information about people and then prioritize people a little bit more based on their need. So it was just really a great example of how research can really inform policy change and support patients. So just wanted to give a shout out to the health authority for that.
Just want to check in with Michelle. Did that answer your question? Do you have a follow-up? And then we can go to O'Neill.
So just to clarify, bonjour Mylène. So Quebec has an algorithm that is based on administrative data, RAMQ Medico, etc.
And a patient survey that is collect for the centralized waiting list.
So is that algorithm public knowledge? Is it published anywhere?
Good question. I don't think it's published anywhere, but from what I know, they didn't use a sophisticated algorithm behind it. They have been to emergency room for a condition over the last 2 years and have been hospitalized. So then they have some point. So it's not a sophisticated behind, but the first is the question that the patient, when they enroll in the centralized waiting list, are you aware of some condition? What is your age? So this is the main where you're going to feel to or be oriented by yourself to which category if you identify, and then the adding with your RAMQ number if you visit recently. So I can find more information related to that if you need. You just have to send me an email. I'm going to be happy to dig a little bit more information about it. And at the end, we have 1.5 million Québécois waiting in centralized waiting. So even if you have so many sophisticated to put in category at some point, that is not helping at the end. But we don't want, but the good news, I know that if you are category A, that's you will have a attachment. They are really prioritized and they really find a physician soon. They don't have a lot of category A. They really manage carefully who is filling a category A. But if you are in this category, you won't wait 6 years. Definitely. It's going to be really soon, less than 1 month. But then if you are LT, that is another.
Given this risk discussion, oh, go ahead.
The big question right now in Quebec is we should move from attachment to family physician to attachment to a clinic. And the Fédération des médecins omnipraticiens du Québec, le FMOQ, strongly recommends right now to change the attachment to the clinic. So that is in negotiation right now.
I'm going to take note of that as a point for additional discussion. Just wanted to pause quickly in case, Colton, you had anything to add about this question of how priority is assigned. There's also a question about pediatrics. You'd mentioned the clinic for really fresh new babies. Just wanted to see if there's anything you'd add, and then I'll turn to O'Neill.
Yeah, absolutely. Thanks for that. So as Emily mentioned, we have there's a survey that's integrated into the Need a Family Practice Registry. It's voluntary, but it's connected to the coordinators use the information to create lists for providers that are accepting patients. There are also incentives for family physicians for accepting patients with who have complex needs, and those two pieces intersect. I also just wanted to add, related to our request for care intake pathway, the way we've been providing care for folks that are coming through that pathway. So they have a defined, chronic disease exacerbation, new diagnosis, whatever the case is. They are linked to the clinic for their care needs while they're there. So we are working on a longer term pathway to community-based health homes through the request for care and its partnership with the registry. But I guess what I'm saying is, if someone comes in with a lung cancer, colitis, whatever it is, their diabetes, their hypertension, their psoriasis is all managed by the clinic at the same time. So it's not just for the one piece. Linkages are still in place for other parts of the system where it makes sense to have a virtual care appointment, etc. But that's the goal would be to provide comprehensive care, especially with folks who are known to have some morbidity.
O'Neill, what's on your?
Yeah, thank you for this. I mean, I think Emily commented early on. I think the natural tendency would be for people with the least need to get attached, because a busy family doc it's not a heavy lift to attach someone who has very limited needs. And so all the structures you guys have described are obviously countering that sort of fundamental inequity. But I'm interested in Mylene's point, and Colton, the point you just made around how good are these, prioritization exercise, how good is this triage exercise? Because fundamentally, if we can identify that subset of people that really need something, and do a good job for them. The fact that healthy people can't be seen for, don't get a family dog for 3 years is probably not catastrophic. And we're working on a ton of constraints. So I'm curious, when I saw Mylene's data, the percentage of people whose needs were unmet in everything that they were triaged to, why might that be? Is it a triage problem? And anyway, I'm just kind of curious on that. And then maybe Colton, as a follow-up question, in that model where you worked, the clinic worked patients up and then handed them off, and it didn't quite work because whatever, they got fit in elsewhere. I'm just curious, what is the information system that facilitates handing off from one thing to the next? So maybe for both Mylene and Colton, what is the information exchange that underpins this, this sequence?
The triage is an important piece, and all the model have been based on that, because the idea it's not everyone will need a physician appointment. So all the system is based, okay, we have less capacity, let's respond to an attached patient, and then we don't need 100% physician appointment. That is the idea. But we didn't develop a lot about our algorithm or the tool to be sure that we are that's response. And sometimes we know that should not go to a physician, because that will be better if for physiotherapist is easy one. But we don't have this trajectory. So a lot of and we observe also, if you are in a region where they have capacity in physician, you're gonna have more oriented by physician because you have the capacity and the system is oriented like that. So that's something there. And as a challenge that I observe, it's really the gap, give really fast an appointment with a physician. That's something new for an attached patient. If you call and you need a physician appointment, you're gonna have in next 3 days. And if you already have a family physician, it's really challenging to see him in 3 days. So now some people say, I prefer to stay unattached because that response, and so we observe on timely access another issue on that, because you really have a system that responds rapidly, but it's based on episode of care with what we know, but it's something really challenging about the delay.
And I guess to add from the Nova Scotia perspective, similarly, triage is something that's new and that's being integrated into the teams in Nova Scotia, so into the PCCs or primary care clinics. So because to echo the previous point, where not every care needs to be seen by a physician or nurse practitioner, nor does everything need to be seen in person. So that navigation triage function is critical for us, especially when we roll into expanding to same day, next day access or self-referral for folks that don't have a regular provider. So those navigation and sort of off-ramp supports to bridge to other service areas is important. I didn't state, and I should have, that these are multidisciplinary teams at our primary care clinics. So similarly, we have pharmacists, we have physiotherapists and social workers and so on, who also carry a lot of the load alongside the physician and NP, their colleagues. From an entry to a health home or permanent family practice standpoint, it is the survey at present that is being used through Need a Family Practice to identify whether someone has self-reported health needs that would kind of expedite or change their status in the registry. So there isn't at this point any other triage that's in place.
And Unil, you asked about the unmet need. That's really something that I'm surprised. We just looked at the result of the survey and say, oh my God, that's a simple question. Are you satisfied of the services? And we were really surprised about the high level of unsatisfied. So definitely we have to dig a little bit more on that, but that is for sure.
And that is one of the things we saw in some of the data where people don't always know what how serious some of their health conditions might be or what the problems are, and if they haven't been seen in a long time. And so it can actually be really challenging to identify. Like, we'll have a little list of like, have you been diagnosed with these things? But you may not have had a chance to get diagnosed and to know how serious the challenges might be. So that equity piece is really hard to tease out on a population level.
I just want to pick up on the thread about information systems and information transfer underpinning some of these programs. Do any of the panelists have points to speak to that question from O'Neill?
Yeah, I'm happy to weigh in on that. So what we use are functions of the EMR system. So we have 2 different EMRs that are used presently in Nova Scotia. So the transfer is at present simply a transfer of the full chart. So in the past, we've actually spent a lot of time, very labor intensively, creating chart summaries. And we created processes and templates to build those summaries in partnership with community family docs and NPs. And we're confident in the template and approach that we had developed, and then found that they actually weren't very useful and people weren't using the summary themselves. So at present, simply transferring the entire chart through an EMR product.
And in Quebec, they're working on trying to do some standardization of the tool, but they are not right now yet. And just to let you know, in the gap, they don't use all the same EMR across the system. So that was really depending of the EMR. Some regions choose the same, so they are quite challenging. And sadly, they didn't start with the same system. So they don't have a lot of information when they have been prioritized. Let's say going to a family physician, they don't have a huge clinical information on it. And they have questions on the chat, can you go for 5 different needs? That is a huge question, and that have been challenging over the 3 years. At the beginning, it was 1 consultation, 1 problem, and that have been a little bit of disagreement about that. They still say you can now do a follow-up with the gap. That's something new. At the beginning, it's one consultation and you have to call back. And now if you see a family physician, he can book a follow-up with the patient. That's something that important as well. But it's why we talk about now the episode of care. But
Just want to turn back. Oh, go ahead.
The length of the consultation is also variable among the physician. Is the physician who has said, I will do a consultation of 15 minutes, or I will do consultation of 30 minutes. So the length of the consultation for patient gap is depending of the suggestion of the physician. I see some place it's 5 minutes, so.
There is still a question in the chat about the specific needs of pediatric populations, people aging out of pediatrician care. And I'd add maybe the topic of integrated use services sites that have been considered or gaining province or attention in a number of jurisdictions. So does anyone have points to speak to on the specific needs of younger folks?
I'm happy to weigh in with a couple developments that where actually the interface with the PCCs are not yet defined, but the Department of Pediatrics here in Nova Scotia has actually created some pediatric primary care clinics where there's both community pediatricians and associate physicians that are paneling kiddos who have complex health needs. So some of our what's kind of happening now in the interim state, this is brand new development, is actually as providers transition in and out of practice. So for example, someone's retiring and we're figuring out the next steps for those folks who are losing their provider. Some of the youth or kids from their panel, where appropriate, are actually being linked to and paneled to pediatric-led primary care clinics.
That's super exciting to find out about. That's because those transition times have always, people talk about it all across the country. So that's really great. And maybe we should get that out once you have like an established program and share that with the rest of the country, because that's great.
Absolutely. Yeah. Let's talk and figure out how we do that, because it's exciting work for sure.
I'll just pause briefly in case there are any remaining questions. I think there's more conversation started than resolved here, especially those questions about the technology that underpins platforms, this tension between moving from episodic to ongoing care, even within models meant to address the needs of unattached patients. And I think definitely examples of different approaches to problem solving across jurisdictions, but addressing similar challenges and opportunities for shared learning. So I appreciate those reflections. I'll throw it to O'Neill if there's one last question, and then we'll wrap things up.
Yeah, sorry, I don't want us to run over, but I know it comes back this idea that the tension between, access, comprehensiveness, and continuity. And so these things that we think of as core to primary care are actually in some ways a luxury because they are in tension. And every example showed how these, elements of high-performing primary care are in tension. And unless you have unlimited, numbers of family doctors, they will always be in tension.
And I think part of that solution is it's not just relying on the family doctors. And I just have an example. I happen to have a family doctor who was fee for service for a long time, and she's just moved into this new clinic called the Mentor Clinic. That's a new experiment that they're doing. I feel so lucky. I had a spell with vertigo. My doctor wasn't available. There was a nurse practitioner that I was able to see. She said, oh, by the way, we have a physiotherapist here today. If you can wait 20 minutes, you can also see that person. And I got all this treatment within one day in a clinic full of allied professionals, all salaried and all supportive. And I think that moving towards these other models where people can get the right care at the right time with the right provider in models that bring together allied health professionals is a really strong way to move forward. And just from my own personal experience, it was incredibly efficient and helpful, and it didn't cost me anything because even a physiotherapist is salaried and it was all covered. So I think there's a lot of room for us to make that system work better for patients. And I think the team models in that area and allied health professionals and having people be able to work to their full scope of practice is part of the solution in Canada.
Appreciate we can rely on you to end things on an optimistic note, Emily. Great to have those solid examples we can hope for. A reminder to complete the survey that will be sent to you. And if there are any of these points that you'd like to hear us follow up on in a subsequent learning series, we take your suggestions really seriously. So thanks so much for your time today. And we'll see you at an upcoming CPCRN learning series.
Merci.